Thanks everyone for joining the EMS Interoperability Task Force call for today, April 13th. We have had a couple calls talking about the regulatory environment and talking about the national networks that are available for interoperability. And we had some kind of loose ends that we wanted to tie up. So we're taking one more call today to kind of wrap up some things on this topic. So just to kind of give you some context of where we are, this is today's topic. And then after today's call, we're looking at heading into some more technical topics as we start to get a better understanding of the actual healthcare data standards and exchange mechanisms that would be utilized for EMS software to talk to software from hospitals and other places. So that's what we're looking at. So today's topic, in our recap, we've got really three main items that we want to cover. We want to really nail down the options that are available for participating in eHealth Exchange, which is a national network, and also options for participating in No2's network. eHealth Exchange and No2 have both applied to become qualified health information networks in the future under the TEFCA framework. And then we'd like to spend some time as a group discussing the idea that came up on the last meeting of creating a position paper or letter for the Office of the National Coordinator of Health IT, laying out kind of, here's the priorities for EMS involvement in interoperability with the rest of healthcare. Okay, so that's the agenda for today. Here's the questions that we hope that you'll have good answers to by the time you leave today. What are the options for an EMS agency, a state EMS system, or an EMS software vendor to participate in the national networks? And how can we collaborate with ONC to advocate for EMS interoperability? So we're hoping to answer those questions. All right, so with that, we're going to hand it first to Jay Nakashima from eHealth Exchange. We've asked him to fill us in on the options for participating in that network. And I would really encourage discussion and questions. So as Jay outlines these options, feel free to unmute yourself and bring in questions that you might have so that you leave this session with a really clear understanding of how that participation might happen. So I'm going to go ahead and turn off my screen share and turn it over to you, Jay.
Yeah, thank you. So hey, everyone, as mentioned, my name is Jay Nakashima with eHealth Exchange, and we're one of the 6 networks, including No2, Commonwealth, Kanza, Epic, and one other that Matt will probably remind me of.
Health Gorilla,
thank you. And we've all had our applications to become QHINs, Qualified Health Information Networks, approved, but we're still not official QHINs yet. We have to go through testing and get some other good stuff done. But at any rate, there are a number of ways that the EMS as a community or multiple communities or EMS entities could join eHealth Exchange. And I might be mistaken, but I would guess that there are going to be, this is going to be very similar with many of the other networks that I mentioned. And so, and of course, there are going to be lots of hybrid possibilities. And I don't have anything visual to share with you. But, when I think about this, I think the most efficient way for EMS as a community to join would be for the U.S. Department of Transportation to join a network like eHealth Exchange or No2 or Health Gorilla. And at a minimum, in my mind, at least in the eHealth Exchange world, that would mean the U.S. Department of Transportation or maybe one of its sub-agencies would sign the eHealth Exchange legal paperwork contract. So they would promise to follow our technical specifications, our privacy rules, our security rules, and so on and so forth. Number two, they would pay our annual fee, and potentially, and I would assume, they would not charge any of its users any fees. So again, in my mind, it makes sense for someone like DOT to join someone like eHealth Exchange as what we call a participant or a member. They sign the legal paperwork and they promise in that paperwork and that contract to flow down all of the legal and technical requirements. And then and of course, again, there are lots of hybrids here. I'm sure a lot of you are gravitating towards the technical side. So they would, at a minimum, they would have to flow down the legal terms and get any vendors who are interested in joining to promise that they're also going to flow down the legal terms to their EMS customers. They'd have to get any EMS agencies to promise to flow down the legal terms to any of their EMS entities. And maybe state HIEs would even join this DOT initiative. Although I believe most, if not all, of the state and regional HIEs are part of the eHealth Exchange already. The big gaps in my mind, who's not part of eHealth Exchange from a state HIE or regional HIE level, are going to be Greater Houston Health Connect in the, I guess, South Texas area, the Idaho HIE, obviously in Idaho, One Healthport in Washington State, and maybe a couple of others I've forgotten. So I know that's a lot but I'm not going to pause just yet. On the technical side, again, this is the most efficient way that I would hope the world evolves. The DOT, again, they join as a participant. They sign the legal technical contract or the legal contracts. And then on the technical side, they implement some sort of a centralized hub and spoke tech platform, interface engine, gateway, repository, whatever you want to call it. And that way, their community, their EMS vendors, their EMS agencies, their state HIEs, whoever chooses to join, doesn't have to do as much technical work. And maybe, I don't know, maybe I'll pause there to see if that concept is resonating and what questions and concerns pop up. And I'm sure that my example with the EMS vendors was probably the most impractical, because I believe that a number of EMS vendors are already doing this through Node 2. And so again, this would be a hybrid where organizations can do it however they make sense. They wouldn't have to join a DOT participation.
Yeah, Jay, let's also, could you talk about the vendor option? Let's say there's an EMS software vendor. They offer a hosted solution, so all of their customers are kind of hosted in a central data center. What would the option be for that vendor directly to be a participant in eHealth Exchange?
Yeah, great point, Josh. So eHealth Exchange does have a few vendors. I'll call, and most of them are EHR vendors, small, obviously. And what they've said is they want to reduce burden for their customers. Again, none of these are on the EMS space. But what they've done is they've said, hey, we're going to join the eHealth Exchange as a participant. We're going to sign the trust contract. We're going to flow down the legal requirements to our customers that want to be part of this. We're going to pay the fee so our customers don't have to. And we're going to provide the tech platform so our customers don't have to build anything or much. And again, they flow down the legal and technical requirements so their provider customers don't have to do so. And so this is something that I believe No2 already does and could happen in a similar fashion with the eHealth Exchange. So XYZ EMS vendor could join eHealth Exchange, sign the paperwork, the contract, pay the fees, set up one technical connection to eHealth Exchange, and then get its interested EMS entities to agree to the eHealth Exchange policy and legal requirements.
Great. And then just for some context for people on the call, the majority of your current participants, would you consider them to be healthcare systems in your current landscape?
Yeah, so we have about 330 quote participants, and most of those are health systems. So most of them have multiple hospitals, clinics, urgent care centers, yada, yada. We have about 60 state and regional HIEs. Some have EMS involvement, some don't. And then we have 5 federal agencies, and then maybe, I don't know, let's say 4 small vendors.
Okay. Yeah, thanks.
Yeah.
Let's open it up so I'm not the only one that gets to ask questions. See what everyone else is thinking. Questions for Jay, and also any comments on what he's shared.
I think I can start. Jay, this is Mario Sanchez from Zoll. We're a vendor. I think we have a few vendors represented here. Are you, you might have said it and I just missed it. Are you proposing, participating in the network from a query perspective for treatment payment operations? Are you proposing, making EMS data either queryable or publishing EMS data through the network, or both, any of the above?
Yeah, I suspect it's going to be a hybrid. And so, I think at a minimum, I think as you understand probably much better than I do, I guess what I'm proposing is the ability for, let's say, hospitals to query EMS for initial observations and whatever else is captured. I think there's also, it'd be important, I would guess, for EMS to be able to query hospitals for outcomes like death. I think, and of course, you probably, there's this scenario where, patients die before they arrive at the hospital, and, there's the death reporting requirements, and that needs to be accommodated. And then I would also love to see the ability for EMS to push notifications to hospitals. The $1 million question there, which Matt might be able to chime in on, or others, is how willing are hospitals and their EHRs going to be to accept those notifications? Because, routing that type of a notification to the right department or the right person, isn't a slam dunk. Yeah,
and I'd say that in our experience, we've seen growing acceptance of that. It's just the mechanics, right? The implementation details of how you get that done correctly. So promise last question, and then I'll let everybody else follow up. So one of the assumptions in EMS, especially if you're making EMS data queryable, one of the assumptions and starting points of EMS, especially for emergent transports, 911 calls essentially, is that we really need to make the assumption that patient demographics is going to be low quality. That an EMS crew going to somebody's house because, finding somebody who's unconscious, or going to somebody's house and rifling through their wallet to get a driver's license while the family's screaming and they're having the worst day of their lives is not going to be workable. So do you have what frameworks do you have, and have you worked with similar things to make the data really queryable, or to enable the push?
I think my most insightful comment is that I'm astounded that I've been in health IT for over 30 years, and we still don't have a unique patient identifier, because I don't have a great solution for that.
Yeah, and I'll jump in here, Jay, as well. I think it's a fair question, Mario, and I don't expect JRI to have a silver bullet answer to that, because that is definitely required. So I do want to take kind of the awkwardness away from Jay as well, and just say none of us have really figured it out, but we've all worked on it. And we can give you like incremental steps to make that better, as I'm sure you're aware. But at the same time, there's no overarching solution to you need demographics in order to get a patient's record.
That's an absolutely fair answer too. Okay.
Yeah. So I think we'll want to put that in our list for things to work on the technical level. I do want to make sure that today we focus on just the options for participating and what would come with participation. So we have these 3 use cases in EMS. One is getting patients' medical history, assuming that we know their identity. That's something that could be supported. Number 2 is getting the EMS report to the hospital. We need to work on how that would happen. And number 3 is getting the hospital outcomes. We know that the hospital outcomes are available if we can identify the patient. So we know that use case is well supported too. We're going to need to dive into the technicals on all of those, but that's kind of the 3 use cases we're looking at. Yep. Let's go over to Jonathan.
Hey, everybody. How are you? Jonathan Fight from Beyond Lucid Technologies. I'm going to be brief on this. I should have put some of my thoughts in the chat here already, but I think I would just like to challenge 2 things. One is, and Jay, since you had mentioned these various mechanisms about how EMS can participate, kind of what an ideal state looks like, we need to differentiate. And I think everybody who's on here is self-selecting for being here, right? So let's sort of recognize that these are all people who care about this topic. I've got Steve Rotman's face in front of me on the list, so I'm going to pick on Wishing for a second. Right? Sorry, Steve. There are some folks on here who've been working on this stuff for a long time. I think one important consideration is that HUHINs are based on fire, not FIRE, but FHIR, right? And it may sound funny to have to point that out in this community, right? But there's a linguistic difference between the structure of the data in the field, in the truck, and the structure not only of what is happening today, which, and Steve made the comment around CCDs and things like that, but there is another link that needs to be made, or another leg up, which is from the CDA structure to fire. Thanks, John. To the degree that we are still talking about a future state, right? And so we've had now several of these conversations as a group where folks are talking about either what has been, to Mario's point on some of the challenges in the past, what is currently today, where there are design implementations being put in place to close information gaps, where there's lots of technology on people's persons, where the conversation about biometrics is, thank God, starting to actually happen. In the real world, where folks say, well, maybe I don't have the ability to go through your wallet, but there are other ways to identify who you are, and those are happening today. And that the implementation of the QHIN structure is still a ways down the road. So there is a now, and that now is going to last for a while. So I just kind of want to bring us to the questions of what are we talking about now, not what are we talking about legacy, and not necessarily what we're talking about for future. But there's like a 24-month period or so in which it's going to hit the fan for patients, right? And assuming that people can just sign up with a network and basically play in the QHIN sandbox is a bit fantastical. We've talked about that on some previous calls here, right? At the same time, there are things that can be done now that don't necessarily require folks signing into an interchange. I happen to work with an organization that is working directly with health information exchanges to make information available both inbound and outbound. So I want to make sure, again, I'm not trying to advertise anything here, but I want to make sure we're talking about the fact that some of the comments represent legacy, some of them represent near and even far future. And there is a window in here that is not really being addressed. And we should bring it back to what is currently possible. And I haven't yet in one of these group calls had us really talk about what people can do right now. So I kind of feel like we should talk about that in some forum. I think, Josh, I'm sort of punting that to you a little bit, but I know we're talking about roadmap, but we're on the road. So let's not forget that there's also a today, and people are doing things, which goes back to the conversations around connect-a-thons and demonstrations and sort of what is real today, and how we take that and blend it with the future instead of assuming we have to wait, or worse, people think that everything that is the future is currently happening, which it's not. And that lends to confusion when folks say, well, what can I do to facilitate interoperability today in 2023, and QHINs are not yet an option. Thank you again to Jay for making that point, that the QHIN process is still happening. It's not yet done. Yeah, that's it. Thanks.
eHealth Exchange and Know2 are both QHIN applicants, but they run networks today. And that's what we're talking about today is their current offerings. It's good to be aware of what's coming in the future, but they currently offer services and have access to data.
And just for to address some of the chat stuff, the vast majority of the transactions going across the US today are SOAP, web-based services, CDA, whatever you want to call it, IHE. As John Murky pointed out, FHIR is growing, but not at warp speed. And I know that because within eHealth Exchange, we have FDA exchanging exclusively via FHIR, and they have been disappointed by the relatively low numbers of providers who will respond to them via FHIR. Most of the providers are still saying that they will respond via IHE only today. That'll change, but not by next month.
Any other questions for Jay before we switch over to Know2? Okay, well, thanks, Jay, for that overview. I really want to kind of leave people with the realization that there's multiple options for participating. Whether it's an individual EMS agency that's a large agency and wants to sign up, or whether it's a vendor. And there's even the idea of, well, does the US Department of Transportation sign up?
Yeah, or does this happen all through state, or it's going to be a hybrid, but state and regional HIEs, does it continue through them?
Yeah, great, thank you. Okay, let's head over to Know2. We've got Matt Becker, and then I see Dane Mueller has joined us as well. And we asked Know2 to also fill us in on how participants might take advantage of their network offerings. And then I don't know, were you going to talk about the operations query stuff as well?
I was, yes,
okay,
as
great.
well.
All right, go for it.
Thanks. I appreciate y'all having us here, and thank you, Jay, for that presentation. You're going to hear a lot of what Jay said in my kind of speech too, because it really is similar in terms of the roadmap we're working with, the challenges you face on a day-to-day basis, things like that. But I can give you kind of the no-two spiel on where we are and where we're going and where EMS fits directly into that. I think part of the bigger picture is that one of the key differences with Node 2 is that we are not necessarily a traditional network. We are a connectivity service. And so what that does for you is we have a set of APIs that folks connect to, usually vendors like Jay was getting at with like his connections to the health exchange. But we really just evolve things around send, receive, and find, those three simple functions. And our job, as we feel our job, is to get rid of the alphabet soup like fire, like IHE, like soap, and everything else. And then have you think of it as, I need to push a message. I need to send a message to another organization. I need to go and query. I need to receive a message from it or find a message from another organization. And so we do the work in the background of interpreting, okay, who are you trying to get that information from? Who are you trying to send that information to? What is the right way to do that? And we hear a lot about her talking this conversation about TEFCA, about direct messaging, things like that. What we try to do is wrap that all into an offering with care quality, eFax, and some other things that we have today, and basically have a way for you to send and find information no matter where it is. And so what we do is we try to take the burden of combining all those networks, combining all those frameworks, and just having a simple set of communication APIs in order to do that. And so I'll give the EMS example, and I know Kasha, if you're on, but we'll pick on Image Trend a little bit since they are a part of Node2's network today. And so what they offer as an example of what an EMS company can do is essentially they connect to our APIs today. So they have access to all of that. They have access to eFax. They have access to Care Quality, which is a network that exists today that has eHealth Exchange, Commonwealth, and others, to where you can find 42,000 other organizations and find the data where your agency or where that run is actually happening. From a direct messaging and eFax standpoint, we can figure some of that out with you and make sure that that message is not only getting to the place where you need it, but to Jay's point and the other points raised in this conversation, we have really worked, and shout out to Dane, we've really worked with a lot of the big hospitals in the regions where Image Trend sees a lot of traffic and make sure to the point of, are they ready to receive these electronically? How are they receiving run reports and things like that? And really working that into their overall workflow. Again, trying to take that burden off of the individual EMS agency so you can do your job. So a lot of that is happening today. To your point, Joshua, it is mainly around treatment. And so when we're talking about HIPAA exchange with Care Quality and others, a lot of those rules of the road only allow for treatment-based queries under HIPAA. The issue that you often run into, and I know you guys are writing a letter to ONC about and things like that, are those operations queries after the fact. And the real pushback in the industry has been the fact that operations just contains so much in addition to outcomes for EMS. That operations query can mean so many different things, including figuring out how to better position your hospital in the future based on patient data, stuff like that. And so it's just this wide swath of things that healthcare institutions aren't super comfortable with today in making those flow freely through electronic exchange. And that's why you often have to ask for fax and stuff like that today. What Node2 has done is worked with individual EMR vendors and others to have individual kind of connections for specifically those EMS queries. Again, in its infancy, I don't want to overpromise what's in production today, but it is in production today to be able to query for those records after the fact, which is technically an operations query. But that does exist today. It does not exist, unfortunately, at the scale of Care Quality and the promise of TEFCA, which is, again, the reason for drafting a letter to the ONC and things like that. So I do want to separate those two and just not overpromise that this is happening ubiquitously across the country today. And so again, it's the history of EMS with No2 it is in one of our just kind of sweet spots of what we're trying to do, which is bring healthcare communication to everybody. Dane is the biggest champion of EMS I've ever seen. He's amazing. And really just trying to push at every opportunity the real life workflows you need, because you are that first point of contact in that emergency. And it's so important in healthcare. And it feels like a lot of these frameworks that exist today, like care quality, were built around, hospitals, clinics, HIEs exchanging with each other, which is super important. But we got to make sure we get all the edges of healthcare, which is what we're really about. To echo some of the things that Jay said, there are a lot of considerations in terms of, vendors joining and making sure that, you connect to our APIs, you accept the legal terms and you flow those down. Those are not going to change no matter who you pick. We are bound by care quality rules. We're bound by direct trust rules. We're bound by TEFCA rules. Those are non-negotiable, and we need to work through those as a community to make sure that everybody's comfortable with that. And I'm happy to join whatever follow-up sessions are necessary to make sure that everybody understands exactly what you would be signing up for. So there's just an understanding across the group. But at the same time, those are real things that you need to make sure that you're following in order to join these trust frameworks, because that's what they really are. They're about trust and making sure that everybody's following the same rules of the road. It gets a little different with us because we're passing along several rules of the road to you, because you're not just joining TEFCA, you're not just joining care quality, you're joining a communication framework that really encompasses a lot of this stuff. So you have to agree to the rules of the road for everything that you're actually partaking of. I think, TEFCA is going to be a little different in its rules. So if you're doing care quality through Image Trend or somebody else today, through us or somebody else, at the same time, you won't be you know that some of that stuff today, but again, there's just going to be more that's coming with TEFCA and stuff like that. But the idea of connecting the No2 is, at least our offering, we try to do that at scale among those networks and frameworks that are out there today. So send, receive, find gets you access to everything, not just TEFCA, not just care quality, not just direct, but eFax as well, and everything else, like including those operations queries that we do have live today in certain pockets of the country. That was a lot. I have a few more points, but I want to pause there to make sure that, number one, that was digestible, and number two, it opened it up for questions on those points.
Yeah, Matt, I'll just, with a similar question, what we asked of Jay, it sounds like one of the options for participating in No2 is for an EMS software vendor to contract with you. Are there other models that you use as well, or is that kind of the main model?
It's the main model for EMS, just because Image Trend is so ubiquitous in the industry that a lot of that happens through Image Trend today. Again, to Jonathan's point in chat, like, it's only a small part as well. So that's the main part we've attacked today. Because, folks can say, oh, I do use Image Trend, I could just sign on there. To Jonathan's point in chat, you're absolutely right in the fact that there are other options out there today, not just for software vendors to join. If you want to join us, absolutely, that's fine. At the same time, if you're an individual group that wants to join us, please talk to us as well, because we do have a UI that's available in order to query yourselves and get information. The thing is that with a software vendor, with Sol, with Samseo, with MedView, with other organizations, what you're going to really need is that software vendor to take a lot of that information and distill it down to exactly what you need. CCDAs are the way that the industry is headed today. But at the same time, that the software vendor can take a lot of that complexity of that huge document away and make sure you're getting the information you need at the time you're getting it. And so those software vendors are important in terms of being able to work that into your workflow and to solve problems like, can we just scan a driver's license and get demographics input and stuff like that. We do work with other software vendors in the space like Samseo and Zoll and some others. At the same time, I do want to make sure that the question is answered in terms of other options that are available. And thanks for the chat, Jonathan. That was really helpful.
Yeah, so a large EMS agency, for example, could contract with you, but in the end, the vendor that they use for their EPCR software has to be involved to actually program the connections. And like you said, program the additional features that allow an EMT to actually digest the information that's coming back.
Yeah, right. And again, to your point, Jonathan, that was not an advertisement. That was just an image trend as an example. I know there are several out there today, and that's just the path that they've chosen to take. And so I do want to make that as an example so others can kind of stand in footsteps. But we do work with others today that have done very, very similar things. And I expect other vendors to do similar things in the future. But to the point that was made earlier, and the overall point I want to make, this does exist today. This exchange exists today. You're able to get this information today. The operations stuff is something we still need to be working on aggressively from multiple fronts, including policy. But at the same time, to the earlier points, this is stuff that is live in production and being able to be done today.
Other questions for Matt or comments? Let's pick a little bit on the query types a little bit. I want to make sure that the people on the call understand a little bit of background here. EMS through these networks can submit a query. Let's say, for example, a query for patient's medical history for or a discharge summary or something like that. And when they submit that query, there's a data element in there that indicates the purpose of the query. Mm-hmm. And that can be treatment, payment, or operations. So when EMS goes on a 911 call and they're coming up on the patient, that's a treatment purpose. They need the patient's medical history for treatment purposes. If EMS submits a query so they can get the patient's insurance info, well, then that's for payment purposes. But when they want the outcomes from the hospital that they took the patient to, that's the query that it would be tagged as an operations purpose. The query itself is exactly the same, except that that data element indicates, oh, this was for a treatment purpose, or this was for an operations purpose. And then the recipients of that query who are going to serve results back, by policy, they may have configured their systems to only respond to treatment queries and not operations queries.
Right. And the history of that is because the treatment query is the only thing that is being required to respond to today. We are currently working on other things on both the TEFCA and care quality front. They're again slow to develop, which is where we need to combine efforts and really help each other make sure that we're getting the right things done first, because there is a long line of things that folks are interested in.
Yeah, so that might be one of the things we'll want to think about as we look at the ONC letter that we're going to talk about in a few minutes, that there are organizations that simply just don't return results for queries that are tagged as operations purpose, not for some technical barrier. It only takes a few minutes to turn on that configuration in their software, but they may not know about that, or they may have other concerns, non-technical concerns. So an area of education perhaps for the hospital side.
Yeah, and why we have, as NO2, have gone around some of those networks and frameworks and really worked with the individual groups to make those happen today. We basically have playbooks to get things moving in the areas you're interested in terms of those operations queries specifically. Again, it's really to narrow down that use case and make the hospitals comfortable with what they're sharing. Again, operations just contains so much that folks look at it like, no way, this is too scary. But when we kind of approach the EMS specific use case, open it up just for that, make sure that they understand everything that's going on, it's a lot more palatable. And so they're open to making those connections. Again, the problem is that we are going one by one through that because the big frameworks and networks today don't necessarily include that as a required response.
Yeah, and this is Mario again from Zoll. I certainly echo that and see that the technology exists. It's possible. It's a little bit of policy, but it's actually more perception and how the partners perceive EMS. Many of them still have the concept of ambulance drivers as opposed to real honest to goodness clinicians. And it feels like education, grassroots education, has some mild help, but certainly pursuing policy to help EMS be perceived as clinician partners is important.
Absolutely agree. Great points. Yeah, and the last part I was going to touch on after my little pause was the operations query, but I think I got that a lot in the questions. So if there are any additional questions on that, I'm happy to entertain them. Otherwise, I'll pass it back to you all.
Anything else for Matt?
Thank you for the opportunity. I really appreciate it. Education is extremely important. I think both Jay and I are appreciative of the opportunity to help out.
Absolutely. Thanks both of you for sharing great information today. Okay, so we're going to move to the third part of our task force call today, which will, in a moment, we're going to talk about this position letter and how we might approach crafting it and what we want to put in it. Before we do that, I want to make you aware of some content that we are developing so far that I think will be useful for that letter. This is the EMS GitHub repository for IHE, and there's a wiki link on it. And this is where we've started to type up things that we've been learning as we've been holding these task force calls. So just kind of setting the stage and then working through the topics. You know, we've been working on the governmental and regulatory environment. We've been talking today some more about the data exchange partners and networks, and we're going to start diving into the much more technical stuff of the content standards and the data transfer standards that will be used. So I've started work on the government regulatory environment page, and I've filled it with links. I want everything written in here to have a reference to something, to have a primary source. So talking about the different types of queries, but really, outlining like EMS agencies that transport and bill for their service are covered entities according to HIPAA. And there's the link to the definition where you can see that that is the case. They have NPIs, they have business associate agreements with their vendors, and so on. That they provide notice of privacy practices. Then it goes on to talk about the 21st Century Cures Act and the information blocking concept, and then some resources at the bottom. So this is something that we might be able to leverage as we think about the letter with ONC in terms of the information that we want to kind of underscore and share with the rest of healthcare. Okay, so let's talk about the ONC letter. I am starting with just some, whoops, back to the right place there. Okay, I am starting with just some ideas that have been presented for what we might include in a letter to the ONC. The idea here is that as a community, we would write a letter to the Office of the National Coordinator that would essentially be received and I guess endorsed by them. I don't know if that's the right word technically or legally, but that they would say, yes, we agree with everything you said in this letter, and that they would be able to use that as talking points with, as they work on their other initiatives with the rest of healthcare. Overall, we want to make sure EMS is no longer left out of all the health IT efforts that have happened over the past decade or two. So these are some initial points. I'll let you take a minute to kind of read through those on your own. And then I want to open it up for comments and discussion. A few things. One, additional points that we can add in here. So I'll just kind of type them in as people talk. Or thoughts on, point number 2 is really important, or whatever it might be. Or things that you think we should not focus on in this letter. So also, if you just have questions about what this letter is about and what our goals are, let's talk about those too. So I'll open it up at this point and see what ideas you all have about what we can put into this letter.
Hey, Josh, this is Dane.
Yeah.
Look, an item I don't see on this particular list, a great list, is anything related specifically to the benefit to the patient.
Okay.
and I'll just, for awareness, I'll just kind of put this out there, is that EMS as a connected care organization, if we talk about individual agencies, care for patients in a variety of settings, some of which are transported to the hospital and some of which are not. And that healthcare information, I'll give you a scenario that's provided to us by the EMS agencies. Mrs. Smith is 80 years old, goes to see a primary care physician. They ask, how have you been doing? And she says, fine. But the reality is she's been attended to by EMS for a falls or for other conditions, never transported to the hospital. And so that information is now invisibly held in EMS data and not being made available to the rest of the healthcare ecosystem. And so I think we need to look at patient, not just outcomes of a transport, but we need to look at the whole care coordination picture about Mrs. Smith.
Thank you. I know that there's got to be more thoughts out there.
Hey, Josh.
So, don't be bashful.
David.
Yeah.
This is David Balcom, David Bryan. I'm a data engineer in Utah. I'd like to highlight the first point, one of the first talking points that we talked about maybe a year and a half ago, or a little bit more, was that EMS is a part of the healthcare ecosystem. It's a critical part because of the bottlenecking as far as bed space and all of the different units. If a EMS cannot get the information, EMS service cannot get the information to do like an inter-patient facility transport correctly, it causes a major bottleneck. And it's one of the principal problems that are faced by charge nurses or different administrative units across the spectrum in inpatient care, not even talking about like post-acute or the other spaces. So it's really a big deal that needs to be addressed. There's patients in a bed in a hallway waiting for a bed because the guys who are going to be doing the transfer are sitting in a 7-Eleven parking lot waiting for a call or waiting for the charge nurse to get them the information. It's the lack of the interoperability in that instance. And I'd like to just highlight that for further discussion.
Yeah, that's interesting, and I think ties in some to Dane's comment too, that in the future of emergency healthcare, this is not just about EMS transporting people around. There's these non-transports, right? The things that can prevent bottlenecks and overloads of other areas of the healthcare system. So that's interesting.
And I'd like to also add, it's not also just in the emergency department, but also, someone being transferred out of the inpatient acute care domain to potentially a post-acute care domain. They have to go by EMS or some other type of medical transport. Most often they just put it, for liability, they'll call Gold Cross, whatever. But it takes so long to effectuate that physical transfer that bed that they're in or that room is not being used, and it goes across the spectrum. Maybe it's not going to affect someone moving from the PICU to the just the medical unit, but it's not just the ER, it's moving patients from one facility to another. That is a tremendous bottleneck.
Bill from Colorado.
Josh.
Oh, hi, everybody. Bill Clark here from the state of Colorado, Department of Public Health and Environment, probably the least techie person here. But along with those lines, the bottlenecks, that's a super key point, and also about the benefit to the patient, about how talking about those who are not transported to the hospital. So that also brings up the key point that in number one, EMS is not only part of the healthy healthcare ecosystem, but it may be the entry point for that specific event or for those specific events. And so, like you said, for the non-transport piece, I know, like in Colorado, some of our agencies that are already hooked into the HIEs, their care record will go into the HIE. The doctor will see, oh, hey, Mrs. Smith, I noticed that we did run on you for this fall, or that they did call an ambulance for this fall a week ago or 2 weeks ago. What happened? So I think it's that key entry point, and if that can be added, thank you.
Thank you, Matt Becker.
Yeah, I think this is awesome. This is a great start on what we're trying to do. One of the things I'm not seeing so far is just kind of the actionable. What do we want them to do? And really breaking that from and then just in my head, I will volunteer 2 things. Number one, since ONC does oversee TEFCA, is really pushing that point as a required response within TEFCA. It doesn't need to be all operations queries, but really this specific subset that's really causing patients to suffer today, and is pretty cheap and cheerful to add, should just be a required response in both TEFCA and possibly care quality. And making sure that folks understand that this is basically treatment and should be treated nearly as such as that, and just be a required response overall. And the second point, really, to the information blocking point, is a clarification or something from ONC saying that operations queries for EMS are incredibly important to patient care, and essentially coming out with some sort of position to folks to say, make this happen under information blocking, and then making that a bit stronger rather than having the overarching information blocking regulations, which affect so much, but at the same time can't narrow it down and focus into what is really affecting patients today, which is this.
Thanks. John Donnelly.
Yeah, hi, Josh. Yeah, I thought reading, just piling on a little bit of kind of number 1 and number 6 a little bit, is the trend towards home-based care, in which EMS could very likely play a bigger role in, or a big role in, not just being the transport party, but potentially providing services that go beyond that. Maybe calling that out somewhere, that this is in support, supporting EMS as a part, I think you stated, a connected care organization, part of that ecosystem that now includes the home, and will include the home more and more.
Thank you. John Hodgson.
Yeah, thanks, Josh. And I would agree with everything that Matt was saying there about the action items and stuff. That's exactly what I was going to chime in on about, totally agree. And the one thing that I don't see here too is just making this a closed loop system, right? And we started this, interaction, and I love that. This is the entry point to healthcare in a lot of cases. So we need to close that loop with the people who started the interaction, and that whole situation about getting the don't block the information, as Matt said, and make this a very targeted request to be able to get that information back. We met with the folks yesterday in Tucson, and it was the main requirement that they had from their fire department and EMS. We have to get outcome data back.
Great. So yeah, that focus on outcome data. Okay. Rob Farnham.
Hi, Josh. Thanks. I guess I'm kind of tying into number 6 a little bit, but the overarching patient safety issue with being connected. I can't tell you the number of times I've been on a call with the patient's family. No, I don't have any medical history. And then they give the medications and it's a full legal size tablet. Or the fact that sometimes the medications aren't updated. So having that sharing of information can be so vital in keeping that patient safe, whether we transport or not. Especially when we don't transport, like has been spoken about, that, we've had the series of falls, but even when we do transport, having EMS have the knowledge of what is actually going on with this patient can be so vital.
Yeah, thank you. That's a great perspective to bring in. Eric Cheney.
Good afternoon, all. Thanks for the great information. Just on the letter piece, two things. Clearly, whatever goes to ONC needs to be actionable with what you're asking for. What should they do? The other piece of that needs to go back to where Jay started out in the very beginning. What should DOT do as the entity responsible for NEMSIS? What are the requirements there? It was suggested that DOT be registered as a participant. So what are the actionable requirements there for DOT? I like the way, I think it was John said that, he sees EMS, but I see EMS as more a gatekeeper. They're the gatekeeper and the entry point into the system. And I think hospitals are going to realize that. And to me, if the hospital is not willing to participate and give back the data that they're responsible for, then EMS should consider transport to other locations where it's feasible. If closing the loop and part of this is evaluating patient care and outcome, if we can't do that effectively for patients transported by pre-hospital care, then we should transport them where we can do that. And no other examples are even more true than stroke, cardiac, trauma, places that have registries, places that have rulemaking in place or statutory authority to be stroke centers, trauma centers. If we're participating in those networks, then they should absolutely be providing that data back in terms of outcome data for the pre-hospital care system that put those patients into those systems. And the last thing I'll say in terms of mobile integrated health and community paramedicine, is there a role for an NEMSIS-like product there? I've been asked by a couple different vendors to create that product. The question is it palatable for the states and other entities that are involved and the vendors themselves? I know Image Frontier is represented and they have a product in place now. So how do those pieces come together for this big picture? Because what we're talking about is, while Jonathan's correct, where a lot of these things and pieces are in place today, what does the next 4 or 5 years look like for pre-hospital care data? Because that's what needs to be planned now to get it put in the federal budget cycle. Over.
Thanks. Jonathan Fite, I think you have to jump to another call, but go for it. Nope.
Hi, yeah. No, I
oh, there you are. Okay.
Thanks, Josh. Yeah, sorry, really appreciate it. And so really appreciate to dovetail on what Eric just said there, because he mentioned the registrars, and I just kind of burned this comment into the chat. There is a missing piece to that part of the conversation that I just want to touch on before I leave here, which is that the data coming back to the crew isn't magic, right? It has to be entered somewhere. And to the degree that folks from ONC, folks from the hospital side are here, it may be worth another conversation, but if the data aren't entered to come back, then they can't come back, right? So I was at the Society of Trauma Nurses conference about 2 weeks ago in Denver, where the registrars at the hospitals were complaining about delays on their side, getting data entered in, right? The quality problems on the EHR side are bigger than on the EPCR side. So again, maybe a conversation for another time, but if you don't have the data available to provide the outcome back, you're not going to get an outcome. And so this is a conversation I have had with many people across the United States. They kind of assume that EHRs are this mystical source of truth, and they're not, right? They're being entered by hand. And in many cases, there are whole companies that are creating scribe businesses again, right? To go around and send televideo and telemedical encounters, whatever, to people who are manually entering data into EHRs. If the data coming back are wrong, if they're incomplete, if they're missing, if they're delayed, there is not currently much understanding on the EMS side about the fact that those data may not be available to be had at all, or in a timely fashion. And they may be, again, identities get confused. People wake up on the gurney and hop out of the emergency department and just leave, right? So there may not ever be a loop to close. And that needs to be understood, that this is two ends of a pipe. And so if all we're talking about is the inbound data and wanting to get data back out through the pipe, we're talking about the ePCR side and the pipe. We need to have an EHR related conversation too. And so if you've got ONC here, I mean, hi, Rachel, and others that are here, they can certainly speak to that. But I haven't yet heard us talk about what we're going to do to make sure that registrars and others are trained and empowered to give data back in a timely fashion, let alone the question of whether you have permission and a need for it, right? It's really a question of, is it there, and how do we make sure it's correct? So you're not incorrectly training people on the fact that the stroke patient actually had something miscoded for them, and now you're actually sending back incorrect information to the crew, which can send them down a cul-de-sac of despair. So thank you for letting me say that. But I just think we need to make sure we close loop on both sides. Have a great day, everybody. Thank you very much.
Thank you. Andrea Forquet.
Hello. I just wanted to add one other thing, and I don't know if it was talked about at some point. I think it relates to the requirements for maybe systems to respond to EMS queries, that being the timing of that response. I think it's really important to notify, not notify, but with the understanding of like when they make these queries, to don't have like that however long, that 20 minutes, and that when it comes to EMS queries to these networks, that there might need to be a prioritization of like the information highway, so to speak.
Andrea, yeah, I can respond to that after you're done. Sorry.
Yeah. No, yeah. I mean, that was the initial piece of the hand raise, is that I just didn't see like the specific of the timing of it. And then just a general response to what Jonathan was pointing out. And I think this is, when we get into data quality of like information not being there when they come in, I think this kind of goes back into that technical discussion of what is being provided at registration for the patient in terms of like identifiers, or understanding that there's error with those identifiers potentially. And then with some of the technical solutions that we're looking for, tying back to, do you need to have those very specific data elements documented by those trauma nurses to send back to the EMS, or is something as good as the discharge summary being sent back, no matter the condition of the patient, to the EMS system, or on the organization side to be able to query a health information exchange for additional information? I think that might have more of a technical discussion piece of what EHRs do and don't have in terms of information. But so that was just my secondary response to what Jonathan had said.
Yeah, and very quickly, John, because I know you have your hand up and I apologize. I think the timeliness is something we have worked out from the technical end, specifically with both the operations query side and the immediate 911, this is an emergency situation. We see in practice, and I think the data quality thing is this whole separate conversation, but what we see in practice with the timeliness is generally the longest it takes to get a message back and the patient's chart back, as the other organization knows it, is around 45 seconds at most. And so, yeah, in a 911 emergency, these networks are well understood to need to be performant. And so those immediate queries that happen in the moment do get responded to quickly. I think the operations query is definitely a separate piece, and we have worked that out technically in terms of when to query and how and stuff like that. But at the same time, we'd be open to feedback a lot in the future of how that would work. And that can certainly be included in this letter as well. But I want to make sure that everybody's understanding where we are today.
That's
Sorry
really
for the
helpful.
interruption.
Thank you. All right, John Donnelly.
Yeah, Josh, two thoughts reading through these items now is, one is like from a technical side, I think we have to also recognize that very often the ED is a separate HIT system than the EMR of the hospital, right? So, and very often the EDIS and the ED itself is not even owned by the hospital. So we have to think of it as a potential separate party that you might have to interact with from the EMS standpoint. And the discharge from the ED is a separate managed item than the discharge from the hospital, right? They could be discharged from the ED into the hospital, and the EDIS has to then talk to the EHR. So just a technical component there, as we were talking about the data availability and where is it and when is it where, and who owns it, right, to respond. The second point is I want to come back to Matt's thought on the action request about the ONC pushing the requirement. For me, the biggest thing here is what is the motivational lever that we will have to kind of drive uptake by the parties. I think a lot of the items mentioned, I mean, the people that are involved probably recognize this as all being true. But what is going to be the lever to actually get them moving? Is it going to be an ONC mandate, something that is driving them from a regulatory standpoint? Unlike the EMR uptake, it might not have a CMS lever that can be actually executed on from an economic standpoint. But I do think we need to think about that in order to promote uptake.
So one of the things I worry about in a lot of these conversations is we're getting to very real cases, very real problems, but we are getting to the 5 and 10% of problems. And the fact that, yeah, there are separate EDs, there are data quality issues, that all is absolutely true. But I do think I want to get to, at least from my opinion, the initial steps of this is the actionable stuff that can happen right away that can break down a lot of the barriers to start having those conversations. Because those conversations don't happen unless that data is actually being exchanged. And so I want to make sure that we're attacking that from two separate standpoints. Number one, you need to open the pipes. And yeah, that goes to the technical pieces that everybody's talking about. And then the second piece is making sure for the edge cases where folks aren't entering data timely, aren't part of an ED that's connected to the hospital, so you're not getting the full chart. We need to work through that from a technical perspective as well, and I think there are answers out there in the community, but my biggest concern for the EMS space is just getting the pipes open to kind of Mario's thing in chat where the operations query is the most important and that's not even available really today. That's the part I want to make sure that gets actionable and gets done quickly so we can attack the rest of the problems that are going to come with that.
Thank you. Yeah, I think this is really important that, you know, we recognize that there's going to be a whole mix of issues to solve over a long period of time. And what are the ones that give us the most the most progress immediately, you know, and let's prioritize those. Let's see, Rachel, I've seen a few things from you in the chat. Wanted to actually give you a chance to speak if you're able to, and you know, just get your perspective on what we've discussed so far.
Yeah, thanks everyone. This is really interesting and timely, as you all know. You know, I really, really highly encourage those of you to somehow get involved with what the RCE or the Sequoia project is now doing as it relates to the standard operating procedures for various things, but in particularly around like the operations queries. It would be good if you all are involved with the payment and healthcare operations exchange purpose that they're in the process of developing. I think that they need to make sure to take into account all of these EMS specific use cases. And I just want to, you know, plug that in because some of this, you know, is not within ONC's control. And so a lot of this is going to have to happen in the work groups, particularly with the RCE and the development of Kafka and making it operational. I know we're having the same conversations on the public health side and making sure that they are at the table and making sure that that's working. So I highly recommend, I mean, that you guys get involved in some way or possible. And if you don't know how, feel free to contact me and I can loop you guys in.
Yeah, and Rachel, just to speak as somebody who is at that table, since we are both represented in TEFCA and care quality on both payment and operations levels, we have pushed the EMS use case hard in both. It has not been the priority, as you can see from the healthcare and operations SOP that was just sort of recently released from TEFCA. That's probably all I can say because I'm under NDA for that group. So I can't say much more, but it is a high priority of us. But I absolutely agree. The more people that can get involved and push this, the better off we are.
Yeah. And I think, Matt, to your point too, if it is out for comment, so I would encourage you guys to somehow provide feedback and comment. It's critical that they hear your point of view.
And I'm interested to hear what Dee Dee has to say, quite frankly. So,
Dee Dee, go ahead.
Oh, thanks, Matt, for the softball there. So yes, it is out for public comment. I know that the SOP is specifically around the standard operating procedure, policies and procedure for TEFCA, but a lot of that work was actually done under the care quality umbrella, which is open to all. Those calls for care quality are open to anyone. They do not have to be a candidate QHIN or whatever. If you are wanting to get more involved with this work, definitely send an email to admin@carequality.org. They'll add you to the list where those calls are happening. There was one today. In fact, there was supposed to have been one this afternoon that was just canceled. But definitely, I know Care Quality is kind of leading the charge, helping develop some of that. And I'm happy to, feel free to send any comments to admin@carequality.org, and they'll make sure they get those folded in. And if there's any links to the documents or things like that are needed, let me know and I'll try to go dig those up.
Great to know. Thank you. Okay, anything else? Any other comments on this letter that we're working on now that my text has got, eventually my text will get so tiny you can't read it anymore and we have to stop, right? Great. Thanks everyone for lots of input and great perspectives and comments. I don't know that we've totally figured out our actual work plan for how we're going to write the letter and draft it and get everyone's input. So we'll work on that and spin this off and see what we can put together. All right, as we wrap up today's call, want to circle back around and say, did we answer today's questions? Which are, what are the options for an EMS agency or its vendor or a state EMS system, any of that, to participate in these networks or network aggregators, as I should have called No2 a network aggregator. And how can we collaborate with ONC to advocate for EMS interoperability? And I think we found some good answers to that. I leave that to you to decide if we answered these questions adequately. So we have developed a quick survey. This is like a 60-second, 100-second kind of survey to do after each of these task force calls so we can make sure we're staying on track. So Lisa's going to put the survey link in the chat in Zoom, or if you want to snap the QR code there with your phone or something. This is just a 3-question survey. It just says, did we adequately address the questions that we had for today's call? Do we need to spend any more time on this topic before we move on to others? And then just a free text box where you can give any other open-ended feedback to help us direct the future task force calls. So we appreciate your participation in that quick survey that you could just do, over the next 5 minutes or so while we're wrapping up the call, if you'd like. Okay, Amit, I'm going to turn it over to you to talk about what's coming up next week in HIMSS.
All right. Well, it's that time of year, and next week we'll be having our HIMSS Global Conference in Chicago, and I think there's going to be a number of folks on this call also participating. And so just wanted to point out a couple things. So one, we have a space in, and by we, I mean the IHE team. And by virtue of that, this NEMSIS project, we have the space in the interoperability showcase called the IHE Learning Lab. And in that, we have a couple different presentations related to EMS. You'll also see on the showcase floor an emergency stroke response and treatment demonstration, which is part of one of the main vignettes in the showcase. And we also have a panel with some of our NEMSIS and NEMSIS TAC colleagues in the education theater that Thursday. And so Josh, Clay, folks and I have been talking about the level of EMS content at the HIMSS Global Conference, as we've been kind of raising some of these EMS issues up at the national level. And so we definitely have more EMS related content in the Interoperability Showcase this year. And we look forward to expanding that to the broader conference in the future years. So for folks that are able to pop in next week, please come by and see us at the IHE Learning Lab in the Interop Showcase. Feel free to contact me or any of us on the team if you'll be there and you'd like to meet in person and have an opportunity to chat. So thanks again, and great call today. Wanted to thank everybody for their comments and contributions. We got a lot of great bullet points for the letter. We have some great next steps around how to participate and provide some comments back to on TEFCA, and looking forward to next steps. So
and I'll echo, yeah, thank you. I'll echo Amit's invitation. If any of you are attending HIMSS and we have not already contacted you for a meeting, which we have done with several of you, then I would love to take some time to meet with you one-on-one or with the group while we're at HIMSS next week. So if you'll be there, just reach out any way you'd like, and we'll get connected and would love to meet and just get your take on how we're doing with the task force. All right, so next steps, do the quick survey for today's task force call. That would be great if you can help us with that. Keep us on track with our future direction. There's the email group that I'm sure you're all part of by now, the GitHub repository and wiki. So I would encourage you specifically to take a look at the wiki site at that repository and start reading through and then recommending additional content that we can write up there. For the May 11th task force, we are going to start diving into data standards that are used for these connections and messages that go back and forth. I haven't totally decided yet how we're going to jump into that, if we're going to look at content standards or if we're going to look at messaging standards, or if we want to first kind of start with a high level of like what's in HL7 and what's in IHE profiles. So we're going to figure that out. But anyway, we're going to start getting into some technical stuff next month, depending on what you say from the survey today, and if we're ready to jump into that.
And one other point Rachel made in the chat, big news in our world as well is ONC has dropped a new proposed rule. So there'll be a lot about that at HIMSS next week, and we'll likely bring that to the May 11 task force topic as well, like at least a summary of the rule, if not more, around some of the public comments and things and how we can support that.
Yeah, Amit, that's great. I think from my perspective, I'd really like to know pieces that are of interest to EMS in particular. I'm thinking like probably the US CDI version 3 proposed for certification might be one of the things. There are some TEFCA pieces in there as well. So trying to figure out just what's very important to you guys, because I think that also would be of interest.
Awesome. And it's actually great timing, right? We're trying to mobilize this community. We've had some progress there, and I think we're in good position to respond.
All right, great. Well, thanks everyone for connecting to our call today. Thanks for all the great input. We'll adjourn till next month. And hope you all have a great rest of the day.
Thank you so much.
Thank you all, and hopefully
you.
see some of you next week.